Yeah, so this international body of research was actually motivated by ongoing questions regarding the etiology of disparities in breast cancer outcome here in the United States. So in the United States, we see that breast cancer mortality rates are actually 42% higher for African American women compared to white American women. And to a large degree, these outcome disparities are explained by socioeconomic disadvantages that are more prevalent in the African American community, with these disadvantages leading to diagnostic delays, a more advanced stage distribution for breast cancer, and barriers to completing comprehensive breast cancer treatment. However, there are several other features that characterize the breast cancer burden of African American women that we really cannot easily ascribe to income or healthcare access inequalities. For example, there's a younger age distribution for breast cancer in African American women. African American women are diagnosed with breast cancer on average 5 years younger than white American women. We have, on a population basis, twofold higher incidence rates of the biologically aggressive triple-negative breast cancer phenotype in African American women. And we also see an extremely poorly understood higher incidence of breast cancer of males in the African American population. So these characteristics prompted us to speculate that there might be something related to African ancestry in and of itself that predisposes to certain patterns of biologically aggressive breast cancer. So our group opted to investigate this hypothesis by studying the breast cancer burden of women from Western Sub-Saharan Africa, where we expect to see shared ancestry with African American women because of the colonial era slave trade. So the patient population that we utilized for this study was initially part of an international breast cancer registry through the University of Michigan. Now it's actually part of an expanded program through the Henry Ford Health System International Center for the Study of Breast Cancer Subtypes. The Henry Ford Health System provides care to the extremely robustly diverse metropolitan Detroit, Michigan patient population, where more than a third of our breast cancer patients are African American. So we compared the breast cancers of nearly 500 white American and African American breast cancer patients from Detroit, Michigan, to the breast cancers of 234 Ghanaian women who were cared for in the Comfort Teaching Hospital located in Kumasi, Ghana. Given our a priori suspicion that African ancestry was associated with some genetic predisposition for biologically aggressive breast cancer, we actually were not terribly surprised to see that the majority, 53% of the breast cancers in the Ghanaian women were triple-negative breast cancers. And this compared to our seeing the lowest frequency of triple-negative tumors in the white American breast cancer patients, at 15.5%, and the frequency of triple-negative breast cancers was intermediate in the African American breast cancer patients at 30%. So we think that this is related to the genetic admixture that we've seen here in the United States. Now, one thing that has surprised me, however, is in looking at the spectrum of very exciting research that's been presented right here at this year's San Antonio Breast Cancer Symposium, looking at treatments and the biology of triple-negative breast cancer. But there's been a distinct paucity of data generated and presented with regard to the disproportionate burden of triple-negative phenotypes in women with African ancestry. So hopefully in the future this will change and we will generate more data looking at triple-negative breast cancer in women with African ancestry, because this represents a very powerful and unique opportunity to understand what is driving the pathogenesis of triple-negative tumors. And hopefully this will lead to better treatments for this biologically aggressive form of the disease. So our study really confirmed previously existing data regarding the fact that African American women face a higher risk of a biologically aggressive patterns of breast cancer, notably the triple negative phenotype, and that African American women are more likely to be diagnosed with breast cancer at younger ages. So these patterns do actually have relevant implications with regard to the ongoing debate about mammographic screening. Now, I, as a clinician, I personally continue to advocate in favor of the National Comprehensive Cancer Network guidelines that American women should initiate annual screening mammography at age 40. The United States Preventive Services Task Force recommends that American women delay mammographic screening until they reach age 50. The delayed screening has the potential for a disproportionately negative impact on the breast cancer burden of African American women and may actually end up widening the existing disparities that we see in breast cancer mortality. So for those clinicians who recommend shared decision making about mammographic screening for women in their 40s and individualized mammographic screening recommendation for women in their 40s, African American identity is something that should be taken into account. So I think that our research underscores the importance of two messages. Number one, while breast cancer screening and early detection is important for all women, I would go even further to say that it is especially important in African American women because of this predisposition, this susceptibility for biologically aggressive forms of breast cancer. The other important message is related to the essential need for recruiting diverse patient populations, and especially women with African ancestry, onto clinical trials and research studying the pathogenesis, the biology, and the treatments of triple negative breast cancer.